present my research project titled Reducing Caregiver Strain, a Multiple Sclerosis Caregiver Support Group Program Evaluation. And just to give a little background, I kind of came upon my topic because during my second year of field placement, I interned for an organization called the Multiple Sclerosis Quality of Life Project. And they're a small organization in Monterey that provides free services to individuals and families living with multiple sclerosis. And if you're unfamiliar with multiple sclerosis, just to kind of give a brief overview of the illness, it is a chronic progressive illness that causes the individuals who have it to have oftentimes decreased cognitive impairments, physical impairments, and emotional impairments. And in working with this population, I also came to work with their caregivers, who are usually family members or friends. So I wanted to look a little bit into the stresses that these caregivers experienced. So to give a little bit more background, the stress that caregivers experience is referred to as caregiver strain. It's also called caregiver burden, and it happens as a result of the caregiving duties and responsibility that caregivers have to perform. And this is especially true in the case with MS, and it causes decreased well-being. In the United States alone, there are 400,000 individuals living with multiple sclerosis. 80% of those individuals will need the assistance of an informal caregiver over their lifetime. So what we know are that interventions are usually necessary to decrease caregiver strain. And at the time that I started this research project, there were no local programs that addressed that issue. So in doing my literature review about caregiver strain, I came across Lazarus and Folkman's stress processing theory, which Sarah kind of already touched on a little bit. But basically what stress processing theory says is that stress is a result of when an individual encounters a stressor and they appraise the coping mechanisms that are available to them. And so in multiple sclerosis, if you're a caregiver, caregiving is that stressor. And MS can be a very unpredictable disease. Oftentimes individuals have flare-ups or exacerbations, meaning that they have a baseline of symptoms ranging from cognitive impairments, visual problems, mobility issues, and those symptoms stay at a baseline, and then for a time period they will flare up. There'll be an increase in the severity of those symptoms, and then they'll return to that normal baseline again. And so as a caregiver, that's unpredictable. You can't predict the amount of care you're going to have to provide. And so the research tells us that additional supports are needed to reduce caregiver strain that happens as a result of those needs. The research also tells us that group interventions for caregivers are more successful than individual interventions, and that social support promotes health-sustaining functions and promotes a general well-being, and the impacts decreases the impacts of stress. So with that in mind, myself and the Multiple Sclerosis Quality of Life Project decided to implement a caregiver support group program in January 2014, specifically for caregivers of individuals with MS. And a program evaluation was used to determine the effectiveness of this program. Which leads to my research question. Did the Multiple Sclerosis Caregiver Support Group program help informal caregivers of people with MS decrease caregiver strain by providing information and emotional support for them to carry out their caregiver activities? So to test this, I used a one-group pre-test, post-test design. I used a convenient sampling method. I sent out an informational flyer in our monthly e-newsletter, and interested caregivers were encouraged to call the office to enroll. Once we had 5 participants enrolled, I facilitated 3 support group sessions over the course of 3 months, each lasting about an hour and a half. So to test the effectiveness, I used the Modified Caregiver Strain Index, the Social Provision Scale, a demographic questionnaire, as well as a program satisfaction survey. And I then entered the results into Microsoft Excel to calculate descriptive statistics. So the Modified Caregiver Strain Index is a 15-item measurement instrument that measures for caregiver strain. Participants answered questions using a 4-point Likert scale, ranging from strongly disagree to strongly agree, answering questions such as, my sleep is disturbed. Items are then summed for a total score, and higher values indicate higher caregiver strain. The Social Provision Scale is a 24-item measurement instrument that measures social support, Again, a 4-point Likert scale is used, and questions are answered such as, there is someone I can talk to about important decisions in my life. Items are then again summed for total score, and a higher value here indicates higher social support. So this is a little hard to read, and I apologize for that, but here are some demographic characteristics of the participants of my support group. And this actually reflects the population of individuals with MS. You can see that 40% were male, 60% were female, 80% Caucasian, 20% identified as being multiple race, 80% were spouses of the person they were caring for. There was just one individual that was a sibling. And 40% were still employed outside of the home. And as I mentioned, MS affects females more so than it affects males, and it has a higher occurrence in individuals from Caucasian ethnicity. So my results were pretty surprising in that they didn't match the literature. Unfortunately, when caregivers were tested at the post-test, their overall caregiver strain scores actually increased by a mean difference of 2. But I'd like to point out there are a few individual questions where their scores did improve. You can see here the question, caregiving is inconvenient. There was a slight decrease in scores indicating decreased strain. I'd also like to mention that in the program evaluation, that the participants actually indicated that they found the support group to be beneficial and that they wanted to continue with the support group even though it was only meant for 3 months. So that's kind of interesting. And here again on the social provision scale, their scores actually decreased, indicating they felt less perceived social support. Surprising. But again, there were a few questions where their scores improved. So for their people who enjoy the same social activities as I do, scores improved. Here are more questions from that and results from that questionnaire. So, as I mentioned, my findings were surprising. They contradicted the literature. Literature says that support interventions are usually beneficial. So you can see in Hogan's 2002 meta-analysis of 100 different social support intervention studies, 83% of the studies found support interventions to be beneficial to participants' well-being, and that's not what I found in my study. But I think there are a few reasons for this. One being that the support group may have increased caregivers' abilities to report their strain. As Huck, Ayalon, and Yoder's study found, reports of increased strain might be the result of support groups allowing participants to feel that they have permission to reveal the strain that they're experiencing. And along those same lines, support groups can be a form of emotional intelligence training, and what that means is during the group, we talked a lot about what caregiver strain was and how you assessed for that. And so it allowed participants to understand the feelings they were having. And in Slavsky's and Cartwright's study, they found that emotional intelligence training actually increased emotional intelligence as well as measures of health and well-being. And as Lazarus and Folkman tell us, by being able to identify emotions and stressors, you can then identify coping methods that you can develop and help to decrease your strain. So even though participants tested worse, it doesn't mean that they couldn't then use some of the coping mechanisms they learned during the support group to decrease their strain eventually. I did face several limitations in my study, the first being a very small sample size. As I mentioned, I only had 5 participants, so I couldn't run any inferential statistics, and my results definitely couldn't be generalized. Also, the screening was a little bit difficult because in MS, because it is unpredictable, the levels of care needed can be different at different times. So I couldn't screen or control for the levels of care people were providing at the pre-test level versus the post-test level. And time constraints were an issue. In most other studies, testing social support interventions, they administered their post-test 6 months down the line. Because of the constraints of our program, I needed to do that after only 3 sessions, which is 3 months. And so who's to say that testing further down in 6 months, their scores might have improved. So overall, what I found is even though my scores weren't as I expected, it still helped Multiple Sclerosis Quality of Life Project implement this new support program and kind of help develop best practice models. So as we continue to administer our support groups, we'll continue to fine tune our trainings for facilitators, recruitment strategies, etc. And as I said, the program evaluations indicated that caregivers liked attending the support group and found it helpful. So we'd like to work on now having the anecdotal results match the measurement instrument results. So I'd hope to be able to report that further down the line. And then if you have questions, welcome.